Hi everybody, welcome to our Facebook Live. I'm Kim Fogarty, I'm one of the PAs here, and I'm here with Dr. Jemsek. This is our third Facebook Live that we've done. The broadcasts or interviews that we've done with Rachel Markey and Carrie Hodges are also on our Facebook feed, so if you scroll down, you'll be able to see the recordings of the question and answer sessions that were done before. There's a lot of good information. As a disclaimer, we're just answering broad questions today, nothing specific to individual cases or treatment protocols, and by no means should this broadcast take the place of any medical evaluation. So if you're having significant concerns, please consult your medical provider. We will be looking at questions from prior Facebook Live events that we were not able to get to. Also questions that have been submitted prior to this broadcast through Facebook, and some questions that were submitted through Instagram. So some of them are real time, some of them are ones that just haven't been answered yet. Okay. All right. To get things going, Dr. Jemsek, do you want to give an update on our GLA study?
Thank you, Kim. So we're actually up and running with the GLA program, and very excited about that. We have 1 or 2 patients enrolled, and we have several in the queue. This is a 30-patient observational study that in which we're collaborating with the GLA, Global Lyme Alliance, out of Stamford, Connecticut. And it's a seminal study, so it's first ever done. We are collaborating with several universities so that there'll be some real science applied to this. And Global Lyme Alliance has decided that they, based on our largely favorable outcomes in our patient population, that we're going to use our treatment program. So they're not going to change anything that we do. And so this is very, quite an honor. And I think is hopefully the first in a whole series of studies to follow.
Okay, let's just as a few housekeeping items, I want to let everybody know that Jemsek Specialty Clinic is open. We are taking new patients. We are seeing patients in the office, and we're also doing telephone consultations and some telemedicine. Patients that come into the office, we are taking infection control precautions. And if you have any questions, please call our front office, 202-955-0003, and they can walk you through some of our screening questions and some of the protocols that we have in place to keep everybody safe. So to get to the questions, first question is, Dr. Jemsek, could you comment and discuss why our patients seem to be very prone to overstimulation, lights, sounds, movement, and so forth?
So the characteristic of this illness is limbic irritability. So the limbic system is below the cortex. It's our reptilian brain, the brain that doesn't think. And it essentially sources all sensory input. So everything that comes through our body, through the spinal cord, goes through the limbic system on the way to the cortex, so our thinking brain. And if those neural pathways are frayed or disrupted, they can be inappropriately exaggerated. And so this results in very disturbing issues with sensory perception, such as light sensitivity, noise sensitivity, startle reflex, and oh my gosh, so all kinds of mood disturbances and so forth and so on. So it's a total disruption of what should be a involuntary reflex, if you will, so that the brain processes things ordinarily that we see when we go out and take a walk outside. You know, we take in all the visual content, we hear things, but none of it's disruptive to us. But with our patients, it's very disruptive and it's very disturbing.
The next question has to do with, is inquiring about why mood disorders are so prevalent in patients with Lyme Disease complex. The way I like to think of the pathophysiology of mood disruptions in our patients is usually due to three major factors. One is that these infections love to attack the limbic brain that Dr. Jemsek was just referring to, and this filter in our brain also helps us to assimilate, process, and respond to any type of emotional stimuli. So if that gets disrupted, that can make people have issues with anxiety, rage, sadness. In addition, due to the impact of the infections on the central nervous system, some of the neurotransmitters that help regulate our moods, most people are familiar with serotonin, norepinephrine, dopamine. Those can get disorganized and chaotic, which can contribute to mood issues. The third, and probably one of the most important ones, is that nobody likes to be sick. Nobody likes to be tired. Nobody likes to have pain. Nobody likes to have their lives disrupted. And that certainly weighs on people's psyches. So emotional health is something that we take very seriously here at JSC, and oftentimes treatment is multifactorial to address all three of those things. Dr. Jemsek, could you talk about methylene blue and how JSC is using it in our protocols?
So methylene blue is a compound that's been around for 130, 140 years. And I'm not sure, I don't really remember what piqued our interest in it, but a year ago or so, maybe beyond that, I began looking at it as a therapeutic agent. And also there's an excellent NIH report that you can find on PubMed out of 2011, which reviews methylene blue. It's an incredible review. And it suggests that methylene blue may help with brain restoration. And now certain parts of the brain don't really restore very well, but certain parts do. And some of the important areas that are able to be restored include the hippocampus, which has to do with memory, and the lateral ventricles, which has to do with processing. So those are well worth redeeming and well worth restoring. So methylene blue, we think, in low doses, based on this report and the animal studies that were reviewed there in this very comprehensive article, is something that we think may be beneficial. We think the risk of taking methylene blue, especially in low doses, is minimal. It will stain the toilet bowl, the porcelain. So if you're taking methylene blue and your toilet bowl turns blue, I'm sorry about that. But we're using it in higher doses for treatment and in lower doses for brain restoration.
Piggybacking on a different antimicrobials that we use, we have a question here. Has Dr. Jemsek considered Finiquin for babesia treatment?
So this is a repackaged old drug. It's been around 50 years. It's Finiquin, which has been used for the liver. So for the malaria parasite, which resides in the liver as a I think it's schizoid or schizoid form. I'm not sure, but at any rate, in malaria vivax and malarium, they tend to recur, and so Finiquin has always been used on a 14-day basis or something like that to eliminate the recurrence of malaria. I don't really think that babesia, which is in the family of malaria, would be affected by this particular product. Again, it's been repackaged, it's been around for 50 years, and it has a very specific purpose, and that's for relapsing vivax and malarium. And I don't think it has a role in our treatment.
And Dr. Jemsek, could you please comment on JSC's thoughts and ongoing investigation regarding Disulfiram?
So too good to be true. It's probably too good to be true. So so I don't totally dismiss Disulfiram, but we certainly don't use it to replace anything that we're doing. we've had so much success for so many years doing what we do based on rather complex, plausible hypotheses. And to think that one drug is going to solve all the problems, all the co-infections, the biofilm issues, the gut issues, I think is just folly. But I also am sympathetic to the vast majority of our populations in this country and elsewhere that they can't access medical care. It's either they can't find it or they can't afford it. And so I'm sympathetic in that regard. So people that take the medication, I don't disdain it. I just think it's folly to think that one drug is going to solve all these problems. And I also don't think that there's going to be the wherewithal to get good clinical trials done and good clinical research done. It just isn't going to happen. So Disulfiram may have a role as an adjunct at some point, and that's something we'll take under consideration, but it is not going to replace everything that we do.
Our next question has to do with pregnancy and Lyme, which is a question that we get quite frequently. We oftentimes, for our female patients, we feel it is ideal and we recommend to achieve remission before trying to get pregnant. And this is for several reasons. One is because if someone has a high infection load and their body is severely stressed, it can be more difficult to become pregnant. And also, unfortunately, I do think we do see a higher risk of miscarriage in our patient population. So it can be more difficult to sustain the pregnancy. It has been documented in the literature dating back into the 1970s that Borrelia can be passed congenitally, mother to baby. So having a low infection load also helps to decrease the risk of transfer to the baby. We do use suppressive antibiotics during pregnancy. These are safe for mother and baby to offer some additional protection. And certainly we follow our patients closely throughout their pregnancy and postpartum. We do work very closely with gynecologists and perinatologists as well. Dr. Jemsek, could you comment on the development of some of the allergy syndromes that can occur in LBC, such as eosinophilic esophagitis, MCAS, and idiopathic hives?
Well, that's an easy one. Thank you, Kim.
You're welcome.
So, yes, so invasion of the GI system is very common. So I think that there's an extraordinary incidence of nonspecific colitis or collagenous colitis. It goes by another name, or lymphocytic colitis, which has to do with, I'm sure, invasion of the spirochetes into the endothelial cells of the colon. And in the esophagus, we have both neural influences, so that you may have reflux because the vagus nerve is denervated and it's not stimulating the sphincter. And so you may have reflux, which is very common. So we see reflux in people that are, not overweight and who are young and who otherwise have no reason to have esophageal reflux, right? And so typically the patients will go to the gastroenterologist and get the usual round of esophageal biopsies and EGDs or endoscopies and colonoscopies and all of that. And we really like to have biopsies done, because if we see eosinophils in the esophagus, we think it's related to Bartonella, for sure. So I think that's a key finding. There are a whole spectrum of gut disorders associated with this illness. And so we're not, so we're just skimming the surface here a little bit. But as far as the histamine issues that Kim alluded to, this has become the soup du jour. And I think the best way to describe histamine and its popularity or its notoriety, if you will, is that it's something we can see, right? So you can be sure that if there's an inflammatory cascade, histamine's there, but it's part of a whole host of pro-inflammatory cytokines. So IL-2, IL-1, TNF, IL-6, they're all there. We just can't see them. So we can see histamine because you blush, or you have a dermal reaction, or you have hives, or you sneeze, and so forth and so on. So to the extent that we can reduce histamine, that's all good. We have several approaches to do that, which are quite benign and largely effective. And so if we can reduce histamine, if we can reduce one of the inflammatory cytokines, to some extent, the patient's going to feel better. They're going to perform better. They're going to function better.
We have a couple questions regarding the GLA study and if there's any additional costs to patients regarding the study, and the answer is no. There's no additional fees or charges for patients who are approved to be participants. Dr. Jemsek, why would someone's B12 level go down in patients with lamborosis complex?
So there's probably an issue with an intrinsic factor, which is produced by the stomach, which helps bind B12 and helps it absorb in the terminal ileum. So on a larger topic with B12, we have for many years empirically challenged people with super high doses of B12 to see if that would help them with their methylation pathways. So if they have key genetic substitutions in the homocysteine or the folate pathways in the methylation cycles, methyl B12 can help overcome that and sort of grease the skids, if you will. And I think about 1 in 4 people will respond to that. And when they do, it's great, because that's another tool to help them, to help our patients detoxify.
And to piggyback on some of the recent answers, we have questions regarding how important it is to maintain gut health in our patient populations. Despite using antibiotics to treat the infections, it's imperative to maintain gut health for immune functioning, for nutritional status, for detoxing. We use high-dose probiotics, and oftentimes we'll rotate them to help maintain the normal gut flora. We use something called Saccharomyces, which is a good yeast that helps keep bad yeast away. It's important for us to use several amino acids, if possible, to help support the cells that line the gut, such as butyrate and glutamine. In patients who can tolerate fermented foods, Dr. Jemsek has his kefir smoothie recipe that he has honed and perfected. And that recipe is on our Facebook page, so I'll refer you to that. It's important for our patients to have a healthy diet and to try to avoid inflammatory foods. We typically recommend reducing gluten, sugar, and any other irritating foods that seem to bother someone's stomach, whether it be dairy or specific food categories. Certainly if somebody has a more complex issues like colitis or the eosinophilic esophagitis, as mentioned before, we do work closely with gastroenterologists. Dr. Jemsek, another question about the GLA study. Does this deal with co-infections as well?
Yeah, so the GLA study is it's brilliant because it's just the GLA folks and the research staff and the corporate staff all understand how complex this illness is, and they appreciate some of our outcomes, or most of our outcomes. And so what we do entails virtually everything, not just all the infections, all the stealth pathogens, but also all the systems that are involved, the gut health, the endocrine system, the neuropsychiatric health, um, cardiopulmonary health, vascular health, dysautonomic health, or autonomic nervous system health, everything. Um, so I just want to diverge just for a second here to say, what we do, I think, and I've said this before, but I want to say it again. What we do here is tremendously complex and misunderstood, and it's been politicized all to hell. And we've survived, thank God. And our patients are from every part of the world because they know that they hope that we can help them. What we do here needs to be its own specialty. It needs to be its own discipline of medicine. We need to have hundreds of trained physicians, not to be just like Jemsek, but to be trained in the science and discipline of this very, very complex illness. And hopefully that'll happen in the next generation. I don't know, but it's what should happen. Thank you.
Dr. Jemsek, we have a question about the importance of targeting the different life forms of the infections involved with LBC, and how does JSC address these?
Well, without getting into all the specifics of our therapy, we understand that there are multiple life forms of the spirochete, but we also understand that co-infections and biofilm play a tremendous role. In fact, I think the major failing of outside physicians who claim to say they can treat this illness is that they don't take into account proper biofilm degradation and killing what's released. So if you break down biofilm, you have to kill what comes out. You have to kill what comes out. Because if you don't do that, guess what? The pathogens populate other cells, infect other cells, and every infected cell is a dead cell. Will die. So that includes neurons. So I would say the major failings are that people don't recognize Babesia as a driver, a major driver. The spirochete is highly diverse, probably the most diverse organism on the planet, the most highly evolved organism on the planet. But by itself, it can't really make people sick unless you have co-infections, unless you have environmental situations, you have lifestyle issues, or if you have genetic issues. So I think those are all key determinants in who gets sick and who doesn't. And of course, our protocol is designed totally on managing the multiple life forms and multiple pathogens that we address. And I would say that to complicate everything, we have a fire in the fuse box where the nervous system is highly involved. And of course, if you have a reaction with, and most people probably understand what Herxheimer is, came out of the 1800s, late 1800s in Europe by a couple of dermatologists who were treating syphilis. They gave them bismuth and arsenic and some other things, and the syphilitic lesions would flare like crazy, and it became very predictable. So that is where Herxheimer came from. So at any rate, so yes, of course, we identify all the life forms that we understand. We identify all the co-infections. We identify all the contributing comorbidities. And we do our very best to do it in a systematic way. And we start slowly, and we do progressions, and we prioritize treatment of Babesia, usually in the first 3 or 4 months.
Dr. Jemsek, could you expand a little bit more on discussing the duration of treatment with JSC patients?
So you know what? It's really been interesting because we've gotten into a pattern where we don't treat everybody the same, of course, and we don't have a formula per se. But we do know that whether a patient is on oral therapy or IV therapy with us, and by the way, IV therapy is only about 15% of the patients that we bring in, and we see some of the sickest people on the planet. But we have well, where we have outliers and exceptions, of course, but in 8 or 9 months, and about 60 treating days or 70 treating days over that period of time, treating, so an average of 8 or 10 days a month, and doing progressions in our protocols, we feel like we get people to a place where they can step down and eventually go to maintenance therapy. And maintenance therapy is for a couple of years. Maintenance therapy is nothing more than 3 days a month of an oral antimicrobial compound and supplements as indicated.
We have a question here about why someone would feel worse when they're on biofilm treatment. One of the main reasons why people will notice an intensification of their Herxheimer reactions when on a biofilm treatment is because as we target biofilm, I like to think of it as kind of like strip mining. We're peeling back layers of infection, and we're able to penetrate deeper into a deeper seated infection. So it's not uncommon for our patients to have increasing Herxing or increasing symptoms as we penetrate into tissues. Now, also using biofilm, anti-biofilm agents in conjunction with antimicrobials also helps to increase the potency of the protocol. So it's not uncommon for patients to become more toxic or more inflamed on the biofilm protocols. Now, that being said, it's very important for your body to remain as stable as possible as you're going through your treatment. So JSC works very hard at maintaining balance within your system and targeting the POEMs that Dr. Jemsek has mentioned before, and mitigating these stressors and flares. Okay. We have a question here about patients who are not comfortable flying to DC given the ongoing COVID-19 pandemic, which is certainly understandable. We are offering an abbreviated consultation, telemedicine consultation with one of our providers to do a general overview of your case and provide some advice and insight with anticipation of seeing you in the office for a full exam and evaluation in the near future. And you can contact our office, our scheduling department, to coordinate that. All right, let me see. Dr. Jemsek, could you comment on the difference between IV and oral antibiotics?
So for a couple of decades, we've differentiated between the oral approach and the IV approach. And as I said earlier, it's about 15% of our folks that are so ill that we just don't think we can get them better with an oral program. They may have severe digestive issues, but mostly it's determined by how advanced the central nervous system involvement is, whether it be dementia or psychoses or any kind of neuropsychiatric disorder that's just extreme and has been disabling. So IV antibiotics, we do have 1 or 2 medications that we use intravenously that we can't. There's no oral equivalent. But in essence, it has to do with drug availability, bioavailability, which is the old pharmacologic mantra that's you got to get drug to the site. And so with intravenous drugs, we bypass the gut and we get much better drug levels. And we think we get much more effective therapy in those patients who are so adversely affected.
I have a question. A question just came in regarding caffeine and treatment. It's okay to use caffeine in moderation. 1 to 2 servings per day is fine. Certainly you want to be careful if you're sensitive to stimulants. It can exacerbate tremors or heart palpitations, or actually can make sleep issues worse in people who are very sensitive to stimulants. Also, you want to make sure to keep in mind that caffeine is a diuretic, so you want to chase it with adequate fluids so you don't become dehydrated. But 1 or 2 servings per day should be fine. Dr. Jemsek, could you comment on the reasons for bone loss? This question is specifically in the mouth in patients with lamborosis complex.
So I'm not an expert on bone loss, but I do know that the so there are osteoblasts which build bone and osteoclasts which break down bone. And this I saw with my HIV patients, many years ago. And actually, I was doing I did some bone density studies and presented them in international meetings and so forth. My 20-year-old HIV males would have osteoporosis. It was incredible. And I think it's all about inflammation. And we know from further studies that vitamin D metabolism and bone metabolism is severely affected by chronic inflammation. And so the Lyme Disease complex is characterized by chronic inflammation. If there's no other unifying term than that, then this would be what you should take home. You're chronically inflamed. It never stops. It's okay to be inflamed from time to time if you're trying to solve an infection or, just going through normal wear and tear processes. It's not okay to be infected or inflamed, 24/7, which is what happens with this disease. And that's why folks are so fatigued, because they can't fire their mitochondria through the electron transport system and make ATP. So when you're chronically inflamed, you're going to have fatigue as a accompaniment to that universally. So as far as bone loss, yes, we'll see not only bone loss, but degenerative changes. So as all this inflammation goes on the spine, so we'll somebody that's in their 30s or 40s for whatever reason has a film of their spine, some part of their spine, and oh my God, they look like they're 70, 80 years old. All this degeneration, and there's no history of trauma. They weren't paratrooping. They didn't jump off their roof, and so this is part and parcel of what we see as part of the inflammatory process.
Dr. Jemsek, could you comment as to why headaches are so prevalent in patients with Lyme Disease complex?
So Kim, you could answer this one.
I know.
So yeah, headaches are multifactorial. So so correct me if I'm wrong, but I think we broadly define them in 3 different categories. Mm-hmm. One is the inflammatory headache, which has to do with your brain wanting to feel like it's going to, in a bubble, you're going to burst, or else a vice, one of the two. It's either centrifugal or centripetal, if you will. So that is due to inflammation of the dura mater, which is where the sensory fibers are in the brain. So the brain doesn't have sensory fibers, right? So you can put a spike in your brain, it won't hurt as long as you ignore going through the skull and the dura. So that is an inflammatory headache. And for that, we try to decrease glutamate production by a cocktail we call Diamox cocktail, which reduces glutamate. Topiramate does the same thing to some extent, but not as well, I don't think. Then we have cervicogenic headaches, which so this infection loves the lower brain and loves the cervical cord, and so our second cervical root is right under the occiput at the base of the skull. C3 is right below it, one level, C4, etc. C4 innervates the trapezius and phrenic nerve and so forth. So what we'll see is a pattern of C2 being so inflamed that and C2 innervates this part of the scalp. Okay, so from here to here. But the volume of the intensity can be so great that it recruits the fifth nerve, the trigeminal nerve. And so now you have a hemifacial headache. So we call that C2V1. That's the headache. And we typically apply a cream here to block the transmission of these rogue impulses. And the third type of headache is due to an increasingly appreciated condition called cervical instability. So the ligaments and tendons of the cervical cord and spine are inflamed, and that again tends to loop in and recruit other neural mediators and create intense headache. Now this typically occurs in somebody that has EDS or Ehlers-Danlos syndrome, or long thin neck, and it can be hard to distinguish. But when we do our examinations, we're very careful about palpating the head and neck area very carefully and trying to determine the source of the headache in that way. But I think, did I miss a category? Okay, thank you.
I'm going to merge a couple questions into one. We have some questions here about why test results in Lyme disease screening would vary even on the same patient. Unfortunately, the testing methodology that's available right now for diagnosing this illness is lacking in sensitivity and specificity. It's not uncommon for our patients never to have a positive test. We look at test results, positive or negative, in terms of how the immune system is able to recognize the infections. In co-infection screening, it can be very difficult to get a positive co-infection test. Oftentimes, when we do our physical exam, we're able to confirm the presence of these organisms within our patients, and they do require treatment. So even without having a positive piece of paper, we look at symptoms, we look at objective findings on exam that can help us track patients and organize their protocols. This is to piggyback on a question we had on how we're able to determine when someone's illness started. When we do our initial consultations with patients, we do a very thorough intake into their past medical history, and to identify comorbid other health issues, and also see if we can pinpoint when these infections may have started to play a role. Oftentimes we'll see a typical pattern in our patients where they may start having some minor issues and their bodies are able to compensate, and then they get hit with a stressor or illness, and the immune system loses some traction and they regress further. And it can be a series of steps, or it can be one specific step where their immune system is not able to tolerate or handle the stressors, and they just are not able to cope anymore. So sometimes we're able to pinpoint it, other times it can be a little bit more difficult. A question here about stem cell treatment in patients with Lyme. This is an area of interest, of keen interest. Unfortunately, we don't have a lot of data pertaining to stem cell therapies. We're looking at it as a potential for helping with healing and recovery, but more information is necessary, and stay tuned in that regard. Dr. Jemsek, could you comment on accelerated dental decay in our patients?
So I don't know a great deal about it, but I know there are tubules in our teeth that quite honestly can get involved by these infections. And now this is a separate issue from gingivitis and a bone decay in the mandible and maxilla. So yeah, we do see accelerated dental decay in our patients, and again, it's has nothing to do with hygiene, dental hygiene, and all it has to do with a predilection for the organisms to infect the tubules of the tooth itself and cause decay. And in the worst case, of course, you're going to get osteonecrosis of the jaw, and we've certainly seen those cases. And that's very, very debilitating and very tough situation.
Piggybacking on that, Dr. Jemsek, what are your thoughts regarding mercury fillings and amalgams?
I don't know. I mean, so people certainly, rush to, remove the fillings, but unless you have a, what is the term for the dentists that are, homeopathic or, biologically sensitive, you can also get a huge intoxication when this is done if you don't have the proper dental approach in terms of all the mercury that's released and will cause issues. So it has to be done with a what is the name of the dentist? A biologic dentist or someone who is very appreciative of the fact that removing the amalgams is not an end to itself. It has to be done carefully. It has to be done under a vacuum, and so you don't get all these vapors and intoxication.
We had a question regarding hyperbaric oxygen therapy treatment, or HBOT. We typically find that hyperbaric oxygen therapy can be helpful in the healing and recovery phase. It has to be approached very cautiously and tailored to the individual, because HBOT can also disrupt biofilm. And therefore, if it disrupts biofilm in an unbalanced fashion and you release dormant infection without having the appropriate antibiotic cleanup in place, it can cause a lot of havoc and a lot of chaos within one's system. So oftentimes we utilize HBOT in patients who are in remission or in maintenance, and certainly proceed with caution in doing so.
If I could just add to that.
Sure.
So I've been involved with hyperbaric oxygen. I've been interested in it for many, many years. We know that at higher levels, the 2.4 ATA, which is like 40 feet underwater, again, as Kim alluded to, if you're in an inflammatory state and your infection hasn't been treated, you're going to bring in, especially at the higher levels, lots of oxidative stress. And so this actually causes more harm than good, clearly. And as Kim stated, that I think that things like bee venom therapy or stem cell therapy or hyperbaric are tools for the future, I think, that will help with healing. And healing is a long process, takes a lot of energy. So once we get our patients better, after a year or so of therapy, 60 or 80 treating days, then they're into a healing mode. And it takes a long time to heal the nervous system and the rest of your body. And so hyperbaric oxygen, I think at lower levels, quite honestly, 1.8, 1.5, which is more like 8 or 12 feet underwater, may be more beneficial in terms of their therapeutic relief and healing attributes.
We have several questions about inflammation and toxins and how to shut down the inflammation. A lot of time, unfortunately, in our patients, there are several key factors that go into why our patients have issues with toxins and inflammation. The main one is, unfortunately, when these infections get the upper hand on the immune system, they are the driving force for the inflammation. So as the infection load goes down, we see quite frequently that patients' toxicity and overall inflammation goes down, and their efficiency in dealing with it also improves. In addition, in our research, we're identifying that many of our patients have genetic predispositions for having issues with toxicity. We've been, our research associates and I has been learning more and more about how to interpret and customize detox strategies based on people's genetic information, and that has been largely helpful. In addition, we really stress detoxing on and off of therapy, and this is ways such as staying adequately hydrated, maintaining efficient gut functioning, Sweating, if somebody isn't horribly heat sensitive. Gentle exercise, Epsom salt soaks, and different supplements and nutraceuticals to help boost natural antioxidant formation to help shut down that inflammation. But and the other aside to that is if there's an environmental toxin or a significant stressor, obviously removing those, if possible, can also be helpful in helping the body lower inflammation and cope with it.
So while she's searching, so Kim summarized that beautifully, but to simplify it a little bit, there are 3 ways to detox, and one is to take exogenous antioxidants because your body is not able to keep up with the inflammatory load and the streaming infections, and your glutathione, the glutathione in the liver is non-existent, it's been absorbed and negated, and so forth. So you take so people take supplements, right? And so we have a list of our what I call tier 1 supplements. And then second, you sweat. You know, people have argued about whether sweating really helps detox. Well, it does. And so we try. So a lot of folks can't do it, so they have to be passive or active. So if it passively, it can be a salt bath, like Kim mentioned, or it can be a sauna if you have access to a sauna. Or if you're a little bit better off, you can do a little bit like exercise so you can generate a sweat. And third is you want to eliminate what you put in your mouth in terms of what's promoting inflammation. So that would be, by and large, gluten-free. And in some folks, as Kim alluded to earlier, they may have issues with soy or dairy or some other things, but mostly it's gluten.
We have a question about cyst formation in patients with Lyme, specifically pineal cysts. Dr. Jemsek, could you elaborate and comment on our on these conditions?
Sure. So pineal cysts are usually an incidental finding on an MR, and they generally don't amount to much. The gland has atrophied in adults by that time. But the other thing we see is microadenomas. We see a lot of pituitary microadenomas, which people get very upset about, and we measure prolactin levels. They're generally under 100 nanograms per cent, and so we see these incidental things on MR studies that we do as basic screening for our patients. But the pineal cyst itself is not a huge issue. It just needs to be monitored and followed, but I've rarely seen any adverse outcomes with that.
We have a question regarding prescription antibiotics versus herbal protocols to treat Lyme-borreliosis complex. There are many herbal products out there that have been shown to have antimicrobial activity. We do use some herbal agents in our protocols to help synergize with the antibiotics. In our experience, a lot of the herbal products aren't as potent, and unfortunately aren't enough to get patients well and to get patients into recovery. So for the vast majority of patients, I think a combination of both prescription antibiotics and herbal therapy is necessary in order to deal with these complex infections.
So we love our herbal products. Okay, so everybody thinks we're just an antibiotic factory. We're not. So I like to say we take the best of the East and West. We just want to get our patients better, and patients will. We've learned most of what we know from our patients who say, "Hey, have you heard about this, or did you look at this?" And I think one of our strengths is that we do listen and we do learn and we're open. On the other hand, we set boundaries because we have experience for 2 decades in treating patients. But we recognize that herbal medications are medicines. They're drugs. Okay, so they have an effect on the body just as tetracycline or beta-lactam or an antibiotic. So, doxycycline doesn't know it's supposed to be an antibiotic, right? It just does its thing, and who knows what else it could do. Look at the story with hydroxychloroquine, Plaquenil, which we've used, in earlier years, and which has been politicized all to hell. Oh my God! Don't get me started. Sorry.
No, don't start. Don't start. We have a question here. Do we see patients from out of state? And yes, we do. We see patients from all over the United States and from overseas as well. Dr. Jemsek is very proud of our map that we have hanging in our main hallway, where you can stick your pin on where you're from. So our doors are open. Okay. Dr. J, can somebody become symptom-free from Lyme?
Yeah, 100%. It's a process, and we have all kinds of experiences and scenarios. I would say that in general, the sicker you are when you present, the more debilitated you are. The less reliant you can be on your own motor. The harder it is to get back, but I've seen people come a very long way and get their normal lives back, and that's our goal. So when we want to do, so our goal is not just to treat these complex infections and this complex illness, but it's to nourish you and to get you to a place where you can do your own immune restoration, which is part of what happens when folks get treated, is the immune system starts to wake up. As an aside, sometimes when the immune system wakes up later in therapy, it becomes angrier. And so people, I call it immune reconstitution, which happened in AIDS, by the way. So sometimes people are very alarmed by that because their immune system's now awake and it's just angry and starting to hit some of the secondary infections like chlamydia and pneumonia and mycoplasma. But I didn't mean to divert from that issue. I'm sorry. So yes, people get better, and so but you need to heal. So first we have to purge infections, and I tell folks we're purging infections so you have a chance to heal, because guess what? If we don't purge the infections, you have no chance. Once you get to a certain point, you're not going to heal. It's not going to happen. You've already exhausted your compensatory mechanisms, whether it's avoiding gluten, working out, sleeping an extra hour, et cetera, et cetera. You've cut back on your lifestyle, and so your life has become your boundaries in your life are much more narrow. So you've already done all that, but you get beyond that point and you need help and treatment. And so, we definitely think we can get you back. And listen, if I don't think, Kim doesn't think, or Rachel or Carrie or Candy, if they don't think we can get you better, we'll tell you. And here are the problems. So that's what our POEMS is about, the POEMS. So we have to have certain things in place before we'll even start treating you. And that has to be a stabilization process.
And just to piggyback on that, certainly diagnosis and getting treatment started earlier is better. But we see patients who unfortunately have been ill for years, decades, that do respond to therapy and do get better. So you can get better. It is a process. It is a campaign. There's a lot of moving parts, but we're used to that, and it can be done. All right. Dr. Jemsek, could you talk about sleep apnea in Lyme patients?
So sleep is one of our principal targets in terms of organizing therapy for folks. And we have, so we can have a sleep apnea, which can be due to, usually to a lax airway, where there's a lot of gagging, or there's either hyper intense gag or no gag at all. Or it can be central apnea, or a combination of both. Sleep studies are somewhat helpful. we use several hypnotics which promote deep sleep. So delta sleep is critically important. We need at least 90 to 120 minutes of delta sleep to get brain restoration. That's when the brain restores itself. It rinses in a sense at night. So our brain rinses at night. If we don't rinse at night, then we carry the toxins into the next day. And so you end up with all this, undesirable brain fog. So sleep is a very complex and very, very critical issue with our patient population.
And our final question for today is a question about how many people do you think are diagnosed with Lyme-borreliosis complex each year? My personal opinion about this is I think that the numbers are very inflated. A lot of the criteria that's used to determine a reportable case, I think, is very antiquated and out of date. Most patients don't fit that criteria, therefore they are not counted. I also think that there are a lot of patients out there that are sick and and have been sick for quite some time that don't realize what's causing their illness. Hopefully in the near future, if we have better testing and better assessment tools, we will see a more accurate number being published. But right now, I think it's not a true number. As a personal side, if you know anybody who is experiencing any signs or symptoms and there's concern that this infection may be contributing to their health issues, we recommend consulting a medical provider who's familiar with Lyme-borreliosis complex to determine, to be evaluated and determine if treatment is necessary. Please don't rely on the testing. Dr. Jemsek, do you have any final thoughts?
No, just thank you for your wonderful contribution and participation as always. So I'm surrounded by these wonderful providers, and I just love them all. And you can tell how skilled they are, and I pretty much pervert all of them because once they get into this field, they can't go anywhere else. And then they've told me that many times. Sorry.
All right, everybody. Thank you for your questions and your input. And again, if we haven't been able to get to your question today, please stay tuned. We save them and we'll keep them for future broadcasts. So keep up the good work.